Good morning, all attendees, and thank you for joining the XLPAD webcast this morning. And we have with us Dr. Marc Peter Bonaca from the TIMI study group, Cardiovascular Division, Brigham and Women's Hospital. Just a few words about Dr. Bonaca. Dr. Marc Peter Bonaca is a cardiovascular medicine specialist at the Brigham and Women's Hospital. He is also an instructor in medicine at the Harvard Medical School. You might all know because he is nationally known for his work in the area of peripheral artery disease, anti-thrombotic therapy, as well as biomarkers in stable and unstable atherosclerotic vascular disease. He has also led and currently leads an interdisciplinary acute aortic syndrome program at BWH. And he is going to talk today about an area which is gaining increasing interest, and that is how to address antiplatelet therapy needs for patients who have peripheral artery disease. So, Marc, please take it away. And his topic today is the TRA2P study, of which he has been a lead investigator, and we're going to share some of his results from the study and some unpublished results, hopefully, Marc, to make this very exciting. And at the end of the session, we'll take some questions. So, Marc, thank you again for joining us this morning from Boston, and I appreciate this very, very much. Please take it away.
Oh, well, thank you. Thank you so much for the invitation. It's really wonderful to have a chance to review some data together and then hopefully have some interactive questions at the end. This is, as you noted, a very exciting area right now. I think antithrombotic therapy for patients with peripheral artery disease is it's an area that's rapidly evolving. And while we are developing new agents and new therapies for patients, it also makes decision-making complicated. And I'll try to sort through some of that in these slides. And so I look forward to people's feedback and questions at the end. I thought I would just start with a descriptive slide which talks or speaks to what I think many of us know in the clinic, and that's what happens to patients who have symptomatic peripheral artery disease over the next 3 or 4 years. And on the left side of the slide are registry data from the REACH registry. I think most of you are probably familiar with that. A large study there, and it was published by Darish Kumbani in the EHJ. And then on the right, these are data from TRA2P TIMI 50, and I'll talk more about that study. But both populations had patients with symptomatic PAD, and if your patient asked the question of what's going to happen to me in the next 3 or 4 years, as you can see, the rates of myocardial infarction and stroke are not negligible. They're important, and we know that. We use therapies to reduce that risk. But in truth, what's most likely to happen to them is limb-related morbidity, and most significantly would be progressive peripheral artery disease leading to some limitation or disability requiring a revascularization procedure. You can see that almost 1 in 4 have a procedure like that. And then you can see that the rates of acute limb ischemia and amputation are similar to those for myocardial infarction and stroke. And so while many of our therapies are targeted to the reduction of major adverse cardiovascular events in this population, which is of course important, we have to remember what the burden that they're likely to see is that of limb-related disease, progressive disease, acute thrombotic complications, and amputation. Because we're talking about artery disease, both progressive atherosclerosis, but also the complications of atherothrombosis, one of the key features of our preventive therapies is antiplatelet therapy and antithrombotic therapy. And this cartoon on the slide shows a platelet with several of the receptors that we have commercially available agents to target. It also shows the coagulation cascade here on the left upper part of the slide, and then a blood vessel wall. And I think the key message to this slide is the complex interaction that exists between the endothelium and smooth muscle of the vessel, the coagulation cascade, and platelets that all work together and hopefully in a non-diseased vessel prevent thrombus or prevent issues with the vasculature, but obviously in diseased states lead to progressive narrowing of the blood vessel, stenosis, atherosclerosis, and also thrombosis, leading to those acute complications we fear the most. Just to review briefly here on the platelet, we have thromboxane A2, the generation of which is the target for aspirin. We have the P2Y12 receptor, which is the agonist of which is ADP, and we have several P2Y12 receptor blockers. We have the different generations here of thienopyridines, with clopidogrel and prasugrel being the most widely used. And then we have ticagrelor, a newer P2Y12 receptor antagonist. And then we also have the PAR1 receptor. This is a receptor for thrombin. When I went to medical school, I always thought of thrombin as having its key role in the coagulation cascade, and it certainly does in terms of cleaving fibrinogen to fibrin. But it's important to note that thrombin is a cellular receptor. It acts on cells as an agonist, and it works through these protease-activated receptors. These receptors are expressed on platelets. They're also expressed on other cell types, including inflammatory cells, vascular endothelium, and vascular smooth muscle. And so that thrombin plays a key role not only in the coagulation cascade, but also in the activation of platelets, as well as having mitogenic effects in the blood vessel wall. And so these are all potential targets for therapies that can attenuate progression of disease potentially and block atherothrombotic complications. The PAR1 receptor that I showed on the prior slide is a target for some novel agents, one that has been brought to regulatory approval, and that's called Vorapaxar. It's a PAR1 antagonist. And because of the nature of the study that you're all sort of collaborating in, I was going to focus most of the time today on Vorapaxar and describing findings with that agent, but I'm happy to talk about other agents later. You know, the key study that led to approval of Vorapaxar for long-term secondary prevention was called TRA2P, the 2P for secondary prevention. It's a study that included a broad cohort of patients, including prior MI, prior stroke, and the PAD group had to meet criteria of either having claudication and an ABI less than 0.85 or a prior revascularization for limb ischemia. And then they were randomized to Vorapaxar placebo, and they could receive standard oral antiplatelet therapy, so aspirin or clopidogrel or both, if they desired. This is TRA2P TIMI 50 overall addition of therapy reduced death by 13% and is significant, and you can see this is over 3 years of follow-up. So overall, the trial was positive, and it was interesting. As a mechanism, PAR1 had not been shown in secondary prevention to be effective. It was shown to be effective here. As I showed, it was a broad population. There was increased bleeding. This is gusto moderate or severe bleeding, and I'm going to talk more about that, but a hazard ratio of 1.66. And importantly, there was heterogeneity with regard to safety. And this has to do with patients with prior stroke, where largely they had an increased risk of intracranial hemorrhage with Vorapaxar that was not as significant in patients without stroke. And you know, when you look broadly at trials, you see this theme comes up in multiple places. So this was seen with prasugrel in the ACS trial called Triton, where the stroke patients had an increased risk of intracranial hemorrhage. This was seen in dedicated stroke trials, including MATCH, PROFESS, and SPS3, where patients had increased risk of intracranial bleeding. And so I think once again we see that potent antithrombotic therapy in patients with prior stroke does result in higher rates of bleeding overall. And in fact, you can see the placebo rate of intracranial hemorrhage was more than double that of the placebo rate of when patients without prior stroke. And so there was heterogeneity for safety, even though there was efficacy broadly. And this led the FDA to approve the drug based on the results of a positive trial, but recognize the harm in patients with stroke and then essentially exclude them from the approval population. So here you can see the population that was randomized in the trial. These were the patients that had prior stroke or had a stroke, history of stroke in the other cohorts, and that led to this cohort of 20,170, which essentially was the population that reflects the approval of the FDA. So currently, Vorapaxar is available and can be prescribed for this population here in the green. When you look at the efficacy within that population, you can see that the addition of Vorapaxar reduced CV death, MI, or stroke by 20% over 3 years. The curves diverge early and continue to separate over time, and that translates into a number needed to treat of 63. One question that was raised was whether this was a durable effect, meaning do you get the benefit early and then stop? Many of us are familiar with the debates that go on about the duration of multi-agent antithrombotic therapy, particularly after coronary stenting. Is shorter better, longer better, and is there benefit in long term here? There really was consistent benefit through the first year, and then over the subsequent 2 years, and over 3 years, there was no heterogeneity in the benefit of the drug. And so this was really shown to be a long-term secondary preventive agent. With regard to safety in the approval population, there was more bleeding. This is gusto, moderate, or severe bleeding. You can see a hazard ratio of 1.55. This was driven mostly by moderate bleeding. If you look at severe bleeding alone, there were more bleeds with Vorapaxar. It was not statistically significant, and a number needed to harm 133. There was no statistically significant excess in ICH or fatal bleeding, but I'll acknowledge here that the numbers are small and there are more here in the Vorapaxar arm, but overall no statistically significant difference. So this was the safety profile in that approval population. With regard to efficacy by the subgroups, was it the same for patients with MI or PAD that came into the study? And here you can see CV death, MI, or stroke. Here, when you add revasc, and you can see overall pooled in the approval population and then split by MI or PAD. And you can see there's no heterogeneity here for the benefit. They're exactly the same. And when you look at net clinical outcome, they're exactly the same. Overall, there's about a 19% reduction in the net outcome, which is CV death, MI, stroke, or gusto severe bleeding. So now I want to drill down a little bit more into our peripheral artery disease cohort. I'll just clarify a little bit what that means, because obviously most patients or many patients have polyvascular disease, right? So they don't have athero just in the legs, but they have coronary disease and prior stroke or PAD and coronary disease. In the way that randomization worked in TRA2P TIMI 50 is that it was hierarchical. So if you had an MI within the last 12 months, you were in the MI cohort, even if you had a history of PAD. If you didn't have an MI, but you had a stroke within the last 12 months, you were put into the stroke cohort. And to get into the PAD cohort, you really had to have symptomatic PAD with no recent MI or no recent stroke. And so this is somewhat of a pure PAD population, in that there's no recent coronary or cerebrovascular event. Nonetheless, you'll see that the majority of patients did have some degree of coronary disease, and I think that's what we know in our practice. In general, when you compare to the overall cohort, you can see that patients with peripheral artery disease were more frequently smokers, more frequently had diabetes and other risk factors. I think that's something that is common. In fact, even 30% or so had renal dysfunction. I think that's also very common in practice. In terms of their background therapy, 98% were on at least one antiplatelet agent, and here you can see the breakdown of aspirin and clopidogrel. About 27% were on aspirin and clopidogrel dual antiplatelet therapy because they were randomized shortly after an intervention. And you can see the use of statin therapy here was high. In terms of their PAD and vascular disease, you can see that 2/3 had a prior revascularization procedure. So these were symptomatic patients, and 2/3 had some procedure. Most had a low ABI, a few had a high ABI, and you can see the Fontan classification here. 3/4 were currently symptomatic at randomization. There were very few that had Fontan stage 4. So we had very few that had necrosis or gangrene, a few that had stage 3, but most were really in the stage 2 to 3 range or stage 2 range. So now I showed you the results for major adverse cardiovascular events, but within the overall trial and the peripheral artery disease cohort, we recognized that there were other endpoints that were just as relevant, and one of those was acute limb ischemia. Acute limb ischemia was a pre-specified adjudicated outcome, so it was collected during the trial and adjudicated. And here you can see that Vorapaxar versus placebo reduced acute limb ischemia by 42%, and that the curves diverged very early, and they continued to diverge over time. And so this was a robust finding that really showed efficacy very early on in the trial. As an exploratory endpoint, this was a non-adjudicated, but it was a pre-specified endpoint. We looked at what about revascularization procedures that were done for any reason. So for claudication, for urgent issues, elective issues. And you can see here, obviously, just looking at the scale, many more patients had a revascularization procedure, so 20% at 3 years. And you can see an interesting shape to the curves here. So over about 1.5 years of exposure, you see very little difference between the treatment arms. But with prolonged therapy, you see that there is a significant and consistent reduction with Vorapaxar that actually was statistically significant. So there's a 16% reduction in peripheral revascularization for any reason. Now, I'll show you a third endpoint that is important in all of the cohorts, but that's ischemic stroke. And here you can see that ischemic stroke was reduced early and continued to be reduced over time. That overall stroke, even when you include hemorrhagic stroke, was reduced by about 32%. And I show this curve also to show you how similar it is to that acute limb ischemia curve, that there is rapid divergence early after exposure and continued divergence over time. Now, when you put these curves next to each other, this is hospitalization for acute limb ischemia, and again, it looked like the ischemic stroke. And here you see peripheral revascularization. You know, one observation that's been made is that these look very different, that the signal for efficacy appears very early for this largely thrombotic event of vessel thrombosis. Here, there appears to be a later divergence, and some have hypothesized that perhaps the mechanism underlying this benefit may be different. Maybe it speaks to other actions of PAR1 antagonism, perhaps not on the platelet alone, but also on the vascular, smooth muscle, and vascular endothelium. Mm-hmm. When you look at other endpoints here within that PAD cohort, you see that there is a reduction in the this broad endpoint of urgent vascular hospitalization, which includes basically MI, CV death, stroke, TIA, and then acute limb ischemia. And if you add these together again here, you have a significant reduction. And then when you look at urgent and elective revasc, you see that there is statistically significant reductions in both. With regard to safety, so this is the patients with PAD in the approval cohort. So meaning this is patients without stroke or TIA that had a history of PAD. And I think this largely reflects what you might see in practice with the drug in a symptomatic population. And as you saw, it's very similar to what I showed before, but the gusto moderate or severe bleeding is increased by with a hazard ratio of 1.5. That's statistically significant. Here you can see components, severe bleeds, it was 36 versus 33. This was not statistically different. For intracranial hemorrhage, 12 versus 11, and fatal bleeds, 5 versus 6. So overall reassuring with regard to severe bleeds, although there were more moderate bleeds that drove this difference. And then all-cause mortality was lower with Vorapaxar with a hazard ratio of 0.95, and this was not significantly different, but I think reassuring when we think to other trials like DAPT, for example, where we saw all-cause mortality go the wrong way, which was largely attributed to bleeding. Now, cross-trial comparisons should be taken with caution because these bars really should not be compared across the different groups. But I think the difference within each trial can be informative. And so the question here is, what is the difference in gusto, moderate, or severe bleeding per year? These are annualized rates with different antithrombotic regimens. And so here we see the Charisma trial, which was aspirin and clopidogrel in red versus aspirin alone. And you can see that there's an increase of about 0.5% per year in gusto, moderate, or severe bleeding. We see a very similar finding in the DAPT trial, which again was aspirin and clopidogrel versus aspirin alone. We see about 0.5% per year. Now, when we look within TRA2P TIMI 50, those that were on aspirin and clopidogrel and then added Vorapaxar as a third agent, so that's triple therapy here in the red, versus aspirin and clopidogrel alone, you can see that there's a difference of about 0.3% per year. And when you look at just adding Vorapaxar to aspirin, so aspirin alone versus aspirin and Vorapaxar, you see that the bleeding is about 0.5% per year, very similar to what you see in Charisma and DAPT. So taking this aside, I would say in general, when we add another antithrombotic agent in stable populations, we see a very similar trend for bleeding, that the cost is about 0.5% per year in gusto, moderate, or severe bleeding. And that also applies to triple therapy with Vorapaxar. So adding a third antiplatelet or antithrombotic agent on top of aspirin and clopidogrel. Now I want to just turn attention to acute limb ischemia. I showed you that curve for benefit with Vorapaxar for acute limb ischemia. These are data I think that are familiar to all of you. It's a New England Journal review authored by Marc, now president of the American Heart Association, that talks about what acute limb ischemia is in terms of a sudden decrease in limb perfusion that threatens viability and tissue loss. Here are data from Sue Duvall and Alan Hirsch's group that were published in 2014. And it says within an all-comers population, what are the etiologies of acute limb ischemia? And here you can see that in this cohort that obviously did not exclude patients with atrial fibrillation, that a number of these events are embolic. And I'll say that within trial populations, because we exclude patients requiring anticoagulation or AFib, you wouldn't see this blue. This is a natural population. And followed by native artery occlusion and graft occlusion, then stent thrombosis, and so on. So these are the etiologies in general. And what have we done to try to prevent acute limb ischemia, particularly from graft or stent failure? Well, there has been one trial, prospective trial, with dual antiplatelet therapy with aspirin and clopidogrel versus aspirin alone. These are 851 patients that underwent below-knee bypass. And you can see that the composite endpoint was an index graft occlusion, the need for revascularization, amputation, or death. And what you can see over time here is that dual antiplatelet therapy with aspirin and clopidogrel was not beneficial relative to aspirin alone for this broad endpoint. So that in this group of patients, which is at relatively high risk for graft thrombosis because they all have grafts, aspirin and clopidogrel was not beneficial. Likewise, for anticoagulation, this was the WAVE trial, which looked at the addition of warfarin to aspirin versus aspirin alone. When you look overall at major adverse cardiovascular events, there was no benefit to warfarin in the PAD population. There was much more bleeding, and I think these curves are quite dramatic. There was a 3.4 hazard ratio for life-threatening bleeding with warfarin. So very high risk strategy here, which did not translate into benefit. And importantly, there was no benefit for limb ischemia. So each arm was about 4%, and there was no statistical difference here with the addition of warfarin. So from the prior slide, we see that P2Y12 inhibition with clopidogrel was not beneficial after bypass, and here vitamin K antagonist therapy, so sort of full dose warfarin for secondary prevention was also not beneficial. Specifically, looking at warfarin for graft failure, this was the Dutch bypass oral anticoagulant study where they took over 2,500 patients with bypass and put them on warfarin versus aspirin. And even with a very high INR, you can see that there was no difference in graft occlusion. So that this was not an effective strategy to reduce graft failure, thrombotic failure. And I think that's somewhat counterintuitive because we think of warfarin as a very potent agent, but it was not beneficial in this large trial. There was more hemorrhagic stroke, and you can see the hazard ratio of 3.48 for hemorrhagic stroke with warfarin. And there was obviously more hemorrhage, a twofold excess. And so this strategy also was not beneficial for graft thrombosis specifically. So now just turning to results from TRA2P TIMI 50 again, to put into context acute limb ischemia, and these are annualized event rates, this is what happened in that PAD population. So these are the event rates per year. If a patient walked into your clinic and said, I have, claudication, no recent MI, no recent stroke, you can see these are the annualized rates. And you can see that acute limb ischemia is more frequent than stroke, more frequent than unstable angina, about the same as amputation, of a similar magnitude to CV death and myocardial infarction. So while not always on the top of our mind for a claudicant, I think we have to recognize that these events are relatively frequent compared to other atherothrombotic events. What were the causes in TRA2P? Well, as I said, because atrial fibrillation patients weren't included, embolic causes were rare. Those were rare. Those are in the blue. And mostly this was surgical graft thrombosis of either a vein graft or a prosthetic graft, followed by in situ native vessel thrombosis and then stent thrombosis. And that was the majority of the events. When you look at how they were treated, you can see that the majority of folks had either repeat bypass or amputation. About 16% had amputation. Some had surgical thrombectomy, then endovascular therapy or thrombolysis only. But if you look at the significance of the interventions, at least half of them are having either an amputation or repeat bypass. And then when we think about, what are the implications of thrombotic complications in populations today, you think of what happens to your typical non-ST elevation MI patient who is admitted, goes to the cath lab and goes home the next day or the day after. Well, this, as reference, is what happened with patients with acute limb ischemia. You can see the median stay in the hospital was 8 days, so more than a week in the hospital. More than a third needed to stay in the ICU. 73% required some sort of surgery. As a Kaplan-Meier rate here, overall, 17.6% required amputation, and 3.7% died. And so these are obviously very serious events given the statistics you're seeing here. And I think one kind of sobering thought is that at the end of that 8-day hospitalization, almost 15% had either died or were unable to go home and live independently because of disability related to their amputation or something else. So 15% unable to live independently or dead is sort of a sobering thought for these patients. When you look at 2 years after their survival for acute limb ischemia, you can see the recurrent rates of MACE, death. 1 in 4 had recurrent acute limb ischemia. More than a quarter had an amputation. And you can see overall 1 in 2 were hospitalized again, so over 50% hospitalized again. So very sick population once they present with this complication. So then we looked at the efficacy of Vorapaxar for acute limb ischemia. This is on the far left here. This is what I showed you with the Kaplan-Meier curves, the 42% reduction. We asked the question of was PAR1 as a target equally effective for the different etiologies of acute limb ischemia. And so here in the first set of bars, we look at graft thrombosis. This is a combination of synthetic and vein graft. You can see there was a hazard ratio of 0.63 And here are the numbers for synthetic and vein grafts. Here we looked at in situ thrombosis. Again, a significant reduction here. For stent thrombosis, a hazard ratio of 0.66, and for thromboembolic, a hazard ratio of 0.5. So when we look across the etiologies of acute limb ischemia, we see consistent efficacy for all of them. Now, turning our attention to the peripheral revascularization signal, again, there was this question of whether there was a benefit with regard to progression of disease here based on the late separation of the curves. Here are preliminary data that were presented in abstract at the ACC last year, looking at the reasons why people had revascularization procedures. So we took those curves I just showed you and dissected it into the sort of the different reasons that drove revascularization. Here you can see there was a reduction in revasc for acute limb ischemia. These are patients where there was a reduction in people that had graft scans to look at patency of grafts and were found to have a severe stenosis. You can see there was a reduction. Chronic critical limb ischemia, there was a reduction. And I think somewhat surprising to us was that there was a 16% reduction in revascularization for claudication. And typically, we have not thought of this as a purely thrombotic outcome, that this really is progression of disease leading to limiting claudication. And in a blinded trial, it was quite thought-provoking or hypothesis-generating that perhaps there was some benefit with regard to progression of disease. With regard to the types of revascularization, we see general consistency across them, but I'll say that even for surgical revascularization, there was about a 40% reduction that was statistically significant. Now, when we talk about, who are the patients that are having these procedures, it's important to note that there is some difference based on whether patients have had prior revascularization or not. But we also wanted to ask the question of whether PAR-1 was effective for de novo procedures or whether it was only beneficial for repeat procedures in patients with grafts. And so here are data that were presented in abstract at the Society of Vascular Medicine meeting in 2015. And you can see on the left side of the slide, these are patients that entered the trial never having had a procedure before. And in 1,100 patients, you can see that there was significant reductions or consistent reductions for acute limb ischemia and peripheral revascularization, which actually would translate to a number needed to treat of 28. For the patients who did enter the trial, about 2,000, with a prior revascularization, you see that there, again, are consistent reductions, but the rates are much higher. So these are a higher risk group, but the efficacy of the drug looks similar. Now, I want to spend just the last few minutes talking about subgroups, and we all in our practice try to say who are the patients that might benefit from this therapy and are likely to have the least risk. I showed you some of the limb benefits that were potentially applicable to peripheral artery disease patients. But when we think generally about major adverse cardiovascular events, one of the subgroups that really seem to have a greater absolute benefit were those with diabetes. And so these are data published by Matt Cavender in 2015. And here you can see in the blue placebo, green Vorapaxar, and the top set of curves are those with diabetes, the bottom without diabetes. Overall, you can see the benefit of the drug was the same. So the relative risk reduction was about the same. There's no heterogeneity. The interaction term's negative. But by nature of their almost twofold risk of MACE, the diabetics had a greater absolute risk reduction of about 3%, translating into a number needed to treat of 30. So a greater absolute benefit in the diabetic patients. And when you put that together in a net clinical outcome of all-cause mortality, myocardial infarction, stroke, or gusto severe bleeding, you can see that there is a 23% reduction in the diabetic patients. It's highly statistically significant. So this highlights one population which appears to derive particular benefit from PAR-1 antagonism. Now, obviously, individual subgroups are difficult to interpret because Diabetics also have more peripheral artery disease. They also have more renal dysfunction and so on. So how do you really integrate all of these different subgroups together? And these are ongoing data, but Aaron Bahula in our group is leading a risk score project which helps to look at simple clinical characteristics which can help identify those patients who are likely to derive the greatest benefit. And you can see data that were presented at the American Heart Association in 2015 here showing that based on the number of risk categories, 0, 1 to 2, or more than 3, you can see that the benefit with Vorapaxar, that's yellow, versus placebo in the blue, stepwise increases from almost no benefit to a 2% relative or absolute risk reduction, and then a 3%, translating into a number needed to treat of 31. And then when you look at gusto severe bleeding, you actually see in the highest risk group you have no excess in bleeding here. And so these risk scores, one has been presented for the DAPT trial. These may be very helpful to us in practice in identifying those patients who are most likely to benefit. Although I'll say when you look at the elements here, they're the elements that you would intuitively select, right? So peripheral artery disease, prior bypass surgery or multivessel disease, diabetes, smoking, and so on, all are useful in that regard. So then in summary, for patients with prior MI or peripheral artery disease, the addition of a PAR1 antagonist to aspirin or aspirin and clopidogrel as long-term secondary prevention reduced major adverse cardiovascular events, so CV death, MI, and ischemic stroke. There was an important absolute risk reduction in certain groups, such as diabetics and those with prior bypass. There was more moderate or severe bleeding. There was a reduction in each of these, including stent thrombosis, and I think importantly to the population that we're talking about today, there were reductions in acute limb ischemia, including graft failure that we believe were largely thrombotic events. And then there was also this very interesting reduction in peripheral revascularization that was driven by revascularizations for claudication, which really I think that finding raises the hypothesis that PAR1 may have broader effects than antiplatelet effects and may have actual effects on the vascular endothelium and smooth muscle. Again, this is just hypothesis generating, and I think additional studies looking at functional outcomes are really critical for us to help understand what the actions of these therapies are. So let me stop there and take questions.
Thank you, Marc. That was an outstanding talk, and I greatly appreciate you doing this. You know, our forum has a predominance of clinical providers who join these webcasts, and I would like to invite them. There's been a lot of people who have joined in the webcast today, so appreciate all the attendees. So if you have any questions, please text me on my cell or onto the text chat, or just ask Dr. Bonaca any questions you have, if anybody would like to do that. I have one question, Marc. I just want to ask you. You know, you said in your talk that that 27% of patients receive Vorapaxar with pre-existing dual antiplatelet therapies. So, just for the audience, how do you, in your practice, decide when you add Vorapaxar as a triple agent, or do you add it? You remove the clopidogrel and replace it with Vorapaxar, or just add it to aspirin alone? So, any strategies of how providers who practice clinical medicine should separate these out and choose one or either of the two strategies?
Well, that's a great question. You know, I think because of the early ischemic benefits, I think there's it is attractive to add it early after intervention because we see that sort of immediate separation for acute limb ischemia. So adding it on top of aspirin and clopidogrel, and most patients are getting a month to 3 months of clopidogrel after intervention. But I'll say in practice, it's sort of hard to put a patient on 3 blood thinners. Sometimes that's difficult as a long-term strategy, and patients will push back a little bit. And so I have, in some, waited until they're sort of outside of the range of their clopidogrel, and they're either on aspirin monotherapy or clopidogrel monotherapy, and then I add Vorapaxar. And I think particularly for the patients that have had bypass and that are on aspirin alone, that's a much easier question.
The question would be on one of your slides, the magnitude of relative benefit, whether they were on single or both, where looked like to be similar to me. So the question would be, would you ever consider a strategy where you would replace clopidogrel with Vorapaxar and leave the aspirin alone? Is that something you have done or at your institution people do?
Yes. Yeah. No. The data, as you point out, the benefit of Vorapaxar is not modified by clopidogrel, and so the benefit was the same on aspirin or aspirin and clopidogrel, and so I usually will, select my sort of monotherapy based on the guidelines, aspirin or clopidogrel, and then I'd add Vorapaxar to either. The benefit should be the same.
And there is a very important question on the text chat, so I want to just ask you, is that someone asked that, no name to it, that whether the dual antiplatelet background therapy relates to only clopidogrel. I think the answer is yes, but I think you should just answer that question and say that is not applicable to other more newer or novel or newer antiplatelet therapies.
Yeah, it's a great question. So because of the timing of this study, we didn't restrict the type of P2Y12 inhibitor, but because of the timing of the study, it was almost entirely clopidogrel, this experience in terms of the safety. And so there were a handful of patients on prasugrel. There were none on ticagrelor. So I in practice, do not prescribe Vorapaxar on top of these newer, more potent agents because I don't know what the safety is, and hopefully that's something that we'll learn in the future. But I generally only use it on top of aspirin, clopidogrel, or both.
Any additional questions from the attendees? If you are, you could also text it to me. I'll give you another minute or two while Marc is on the line. Marc, thank you again for joining in on this fantastic webcast. If you don't mind, we'll be posting the audio and the video of this online, and if there are any additional questions, we will pass them on to you if someone wants to get in touch. We also add a multiple choice questions to your slide deck, and we will have you approve it and then post it along for the audience to test their knowledge based upon the talk you've just given today. Thank you, Marc, very much. And again, thank you all attendees. Again, thank you for joining in on the XLPAD webcast this morning. Marc, that was great, and we look forward to having your participation in many of our joint collaborations in the years to come. Thank you so much.
Well, thank you. Really, really appreciate it. Thank you.
Thank you. Bye-bye.
Bye-bye.